Welcome to CME on ReachMD. This activity, titled Case Challenges in Systemic Mastocytosis, Clinical Insights from the Expert Roundtable, is provided by Clinical Care Options LLC, doing business as Desera Clinical Education. Prior to beginning the activity, please be sure to review the faculty and commercial support disclosure statements, as well as the learning objectives.
So what is mastocytosis? It is a neoplastic disorder. So it's not only just increased activity of the mast cells, but also there is increase in number, and there is accumulation of those mast cells in a clone, whether in the skin, and this is called cutaneous mastocytosis only, and then systemic mastocytosis, where you have extracutaneous organs involved. You can have involvement in the bone marrow, in the liver, in the spleen, among others. And then you can have that without involvement of the skin. And then the last type is the mast cell sarcoma, which is a very rare type and usually very, very aggressive. Systemic mastocytosis is definitely not the same as MCAS. We're not really going to be discussing MCAS because that's by itself like a lecture, but you do have mast cell activation in systemic mastocytosis. So you can have symptoms that looks like MCAS, but really the two terminology are not equivalent. So what happened? What's the pathophysiology of mastocytosis? You do have a stem cell factor that trigger that KIT receptor on the mast cells. In mastocytosis, there is a KIT mutation and there is a gain of function. So this will lead to activation of these mast cells without really a lot of triggers, and then that will lead to overactivation and then more release of histamine, prostaglandin, among other just like activators. And then this will lead to more symptoms like itching, flushing, fatigue. You can have anaphylaxis, osteoporosis, and GI as well, like abdominal pain, diarrhea, and we'll talk about more other symptoms involved in mastocytosis as well. So looking at the patient reported symptom, like what they are bothered by mainly, it's mainly the skin related, like with the flushing and itching. So this is what we see a lot in our clinics, and GI. So skin and GI are really big for those patients. And then anaphylaxis is the most scary one for the patients when it happens. Fatigue, exhaustion, and then like you have all the spectrum of non-specific skin symptoms and like just like symptoms like fatigue, being like depressed, or like brain fog, or like just weakness, like they don't feel themselves. So by itself, they do have very non-specific generalized symptoms as well. And then looking at the score here, so this score looks at like the overall how the patient is feeling overall. So like kind of similar to like a quality of life. And then if it's less than 1, so 1 is you're at your best, and then less than 1, that means like you're really not doing very well. And as you can see here, the advanced systemic mastocytosis definitely have a lower score than an indolent systemic mastocytosis. But even overall, the patient will not be feeling very well when they have this disease. So adults versus peds mastocytosis, this is an important distinction. We lump them into the same disease. Some people think they're a little different because how they present and the prognosis of those two different diseases. So in adults, you do have most of the time indolent systemic mastocytosis. So you or if you do have skin involvement, please check a bone marrow. Make sure your patient, even if your tryptase is normal, you want to make sure that your patient does not have systemic involvement. For peds, there is really no criteria for that. Most of the time, it is in the skin and it remains in the skin. It starts looking more scary. It's very polymorphic. They can blister, and it definitely like very, very scary for the parents. But usually they do well, and it resolves eventually. And the anaphylaxis in pediatric patient is less likely to happen compared to the adult patient, where it can happen in about 50%. Tryptase level in adult is usually higher, more than 20. And then the KIT mutation, the D816V, which is like the most common mutation that we talk about in mastocytosis, is more prevalent in adults. And then we have tons of other mutations in kids, and sometimes you don't find much. And this is why people think like, are these really the same family of diseases? Very monomorphic, red, orangey, kind of like brownish look on the skin for adults. They all look the same. They can start like they start on the thighs, go up to the trunk, usually does not cross the neck. So like head and neck, head usually is not involved in adults, but kids actually, they do have head and neck involvement, and that's one of the characteristic features. So this is what we're talking about. This is the monomorphic small lesion that are typical of indolent systemic mastocytosis in adults. You can have like few of them, and you can have tons of them, like the initial picture. And sometimes they cause the skin to be a little darker look, so it gives like a different tone on the than the actual kind of like skin type of the patient. And then in our kids, as you see, like bigger lesion, they can blister. They look different in size and shapes, and but they usually do actually better than the adult. So again, like adults, you always want to rule out indolent systemic mastocytosis. It's very rare to be only a cutaneous disease. It is skin manifestation is very common in indolent systemic mastocytosis of adults. Derrier sign, which we mentioned initially for our case presentation, this is like when you rub the lesion, it causes like more swelling. So it releases all the histamines and prostaglandins and all the other markers to cause like more swelling and redness of the lesion, and it's usually present. And then again, they start on the thigh and go up to the trunk, distal extremities, and neck, and usually avoid the face for adults. So this is the diagnostic algorithm for mastocytosis. If you have a suspicion of mast cell symptoms and you have anaphylaxis and you have some elevated serum tryptase, or if you do have adult onset skin mastocytosis, biopsy proven, then those patients need to have evaluation for like more systemic disease. So biopsy, bone marrow, and like or other involved organs. And then you want to really do that molecular testing of the KIT D816V. It's best done in the bone marrow and the blood, but you can do it on the skin as well. It's not as accurate, however. Mast cell immunophenotyping in the bone marrow in particular, and then you want to screen for the main mutation, which is the KIT. But if it's negative, you can screen for this other mutation, which is FLIP1 PDGFR, and then you can look for eosinophilia if it's present. So diagnostic criteria, we do have major and minor criteria. The WHO classification needs one major and one minor criteria, or more than three minor criteria. I think the international consensus is a little more loose with one major criteria and like more than three minor criteria. So again, major criteria, you need to have multifocal dense aggregates of mast cells, more than 15 in the bone marrow and or extracutaneous organs. And then the minor criteria, you need more than 25% of the mast cells to be of atypical morphology. Usually they are round under the microscope, but what they mean by atypical morphology, they become like more spindly, more elongated, and then they have the aberrant expression of CD2, CD25, and or CD30 expression on the mast cells. This is again done in the bone marrow. I don't usually do those on the skin. They're not very relevant. KIT D816V mutation in the bone marrow or like on the skin could be done as well. And then the serum tryptase more than 20 in the absence of any other myeloid neoplasm. Why this is important? Because if you do have another myeloid neoplasm, you can have high tryptase, and that might be like completely different. You really don't have like, it doesn't need to meet the criteria. So this is, I think, the gist of what we talked about in our question. Like, so there are multiple subtypes. We see what we see mainly is that indolent systemic mastocytosis, which is the most common presentation. Typically, they have skin lesion. They usually are non-advanced, but they do have like significant skin lesions. Usually, they don't have like a lot of other involvement other than just like the bone marrow, and then their tryptase would be more than 25, 125, and then usually less than one of the B findings, meaning like the systemic mastocytosis burden, so hepatosplenomegaly, lymphadenopathy, all of that. So you don't like the patient is not super sick, but they're definitely having symptoms and mainly skin symptoms. The bone marrow mastocytosis, that's a tricky one. I think a lot of you thought about that on our case, but usually they don't have skin lesions. So this is a very important distinction between the bone marrow mastocytosis and the indolent systemic mastocytosis. Both of them are not advanced. The bone marrow mastocytosis really does not have B or C findings. It's kind of like brewing in the bone marrow, but still like not, it didn't really release itself yet. Smoldering systemic mastocytosis, you don't have a lot of skin lesion, and then you do have more B findings, so hepatosplenomegaly, cytopenia, lymphadenopathy. You don't have any C findings where you have like organ damage. And then you do have the more advanced one associated with hematologic neoplasm, and this will follow the specific hematologic neoplasm criteria, or you have the aggressive systemic mastocytosis where you have damage with involvement of these mast cell infiltration of the organ, and then you'll have more severe symptoms. And then like the MC leukemia, as we mentioned before, it's a very rare finding where you have more than 20% in the bone marrow and then in the blood as well. So kind of like more circulating. And then the other thing I want you to think about, like whenever it becomes more internal, they kind of lose their skin lesion and everything becomes like more in the blood in the other organs. So the differential diagnosis is very wide. And then you do have like the mast cell activation syndrome that we just mentioned, and then you have idiopathic or monoclonal, and then you have just like patients that have anaphylaxis or angioedema. But then you also have the other derm problems that could look like flushing, itching, so chronic spontaneous urticaria, atopic dermatitis, rosacea. You have endocrine, so definitely you want to check their thyroid. You want to look for carcinoid syndrome. You want to make sure with all their GI symptoms like IBDs or IBS. And then again, neurologic. So that's a big one. They have headaches, seizures, strokes, dysautonomia. And then again, like the psychological anxiety, panic attacks, depression. So a lot of ruling out while you're doing your diagnosis. A very good like history and review of system would help you a lot on that case. So we're back to our post-test questions. So Julian, again, is the 36-year-old man with a history of spreading small lesions on the skin who received testing for systemic mastocytosis. His finding included a KIT mutation that's positive, serum tryptase of 48, and a dense multifocal bone marrow mast cell aggregates. Based on these findings, which systemic mastocytosis subtype he's most likely presenting with? Indolent systemic mastocytosis, bone marrow systemic mastocytosis, smoldering systemic mastocytosis, or aggressive type systemic mastocytosis. Okay, let's see the polling. Okay, so that's great. So we do have like more voting for the indolent systemic mastocytosis, which is the accurate diagnosis. Again, the difference between this and the bone marrow one is like that skin involvement that's very prominent for indolent systemic mastocytosis. And this patient presenting with these red lesion and he has a positive diarrhea sign. So just remember, you definitely need to do a skin biopsy to confirm skin mastocytosis. But this is like with these criteria on like having KIT mutation, having the tryptase, and having the bone marrow infiltrate, and the skin lesion will make him fit the criteria for indolent systemic mastocytosis. And this is what we were just discussing. So WHO guidelines again, systemic mastocytosis, KIT mutation, high tryptase, and then dense multifocal infiltrate. And he has like 1B findings. And then he really like the bone marrow. I think that's the one that was like very tricky for y'all. The bone marrow in particular does not have a lot of skin lesion compared to the indolent systemic mastocytosis. Okay, I'm gonna see if we have like some questions here. Okay, sorry, I think we have one. Okay, so when you see B or C findings, how does that shape prognosis or follow-up discussion with patients? Yeah, that's an excellent question. So if we do have, so first, like if we do have these findings and then we have referred to our colleagues in hematology, oncology, and then they did the bone marrow, I think like it's very important, and like allergy immunology, and then like they have started the treatment. It is important for us to see the patient in clinic closely and follow up on the skin symptoms as well, because like they usually do really well like when they start their treatment with like their organ involvement, but sometimes the skin lags behind. And then I think Dr. Giannetti going to talk a little bit more about treatment. And then this is important for us because we do have some modalities that help, but unfortunately sometimes we cannot really control their skin the way that the patient is expecting. But it is like more, I think if they do have the B and C findings, that means like more close follow up on those patients to make sure they're not going into more advanced stages. And then now I'm going to hand it to Dr. Giannetti to talk about more therapies for systemic mastocytosis.
Yeah, excellent. Thank you, Dr. Bitar. I would say that question dovetails quite nicely into my section here. So targeted therapies for systemic mastocytosis. Typically, if you have B or C findings, it does represent a more aggressive disease. So oftentimes we're talking about some of the tyrosine kinase inhibitors. So with that said, let's start off with a case report here. This is Darren. He is a 44-year-old man with a 2-year history of known indolent systemic mastocytosis. He was referred to dermatology after developing persistent itchy reddish-brown lesions on his torso. These spots, as typical with cutaneous mastocytosis, worsen with heat and friction. And he's here because he basically wants to discuss treatment options that may work to improve quality of life and improve his lesions. So briefly on his past medical history, he's had a couple prior episodes of presyncope. He's on cetirizine and montelukast. And in his laboratory findings, he does have the KIT D816V mutation. He does not have any other non-KIT mutations on a myeloid NGS. That's an important finding here. His tryptase is 58 nanograms per milliliter, and he has dense mast cell aggregates in the bone marrow biopsy. So you can see right there, that's a major criteria and 2 minor criteria for systemic mastocytosis. Okay, so for Darren, indolent systemic mastocytosis with KIT mutation, we kind of went through his information here. So for 6 months, a combination of anti-mediator therapies improved itching and diarrhea, but there was little improvement in his cutaneous lesions. So based on the PIONEER trial, which statement would be correct when discussing the impact of avapritinib on his symptoms? I won't go ahead and read A, B, C, D here for you. I'll let everybody read it themselves, but why don't we pause for a minute, let you read and answer the question. Okay. So it looks like most people had answer B, avapritinib improved skin lesions when used in combination with topical corticosteroids. So let's go through the teaching section here, and we'll bring it back to answer this question more definitively. So when I think about treatment of mast cell mediator related symptoms and really treatment of mastocytosis in general, I kind of think of 2 defined pathways. So the first pathway is going to be the tried and true mediator related symptoms. So typically antihistamines, leukotriene receptor antagonists, et cetera. And then the second pathway is going to be tyrosine kinase inhibitors. So let's spend a slide or 2 here focusing on the mediator related symptoms. Subdividing this further, when I think of mediator-related symptoms, I kind of think of a targeted organ therapy effect. So skin here, lots of itching, hives, flushing, angioedema. Typically, H1 and H2 are the first-line therapies. So in my clinic, at least, I like cetirizine 10 milligrams twice daily, and often famotidine 20 milligrams twice daily, kind of as an initial start, and then up titrating, down titrating from there. Alternative options, I use quite a bit of montelukast. We could use aspirin, ketotifen, topical cromolyn. I use less topical cromolyn. I think oral cromolyn is a little bit better, but all of these are viable options. GI symptoms are probably the second most common grouping of symptoms in mastocytosis. I lean quite a bit on H2 antagonists, so famotidine. Cromolyn can be quite helpful, as can PPIs. As it turns out, histamine can directly activate the parietal cells of the stomach and small intestine. So histamine oversecretion or overproduction from mast cells leads to acid hypersecretion. So gastrointestinal reflux disease and reflux in general is much more common in patients with mastocytosis. And then as you can see here, kind of going down the list, in all of these organ systems, we typically use H1 and H2 as a first-line therapy for really everything. A couple of specific call-outs I would like here. So for cardiovascular, you see presyncope and tachycardia. This is most typically in the setting of anaphylaxis. I'm an immunologist by training here, and we use quite a bit of omalizumab for things like this. It works phenomenally well for anaphylaxis. For patients with intermittent hypotension, presyncope, et cetera, I would strongly encourage you to get them over to immunology so we can use omalizumab. And then occasionally we'll use corticosteroids, both inhaled for the lungs and more commonly topical, even systemic for acute flares. Okay, so moving forward here, a couple of other systemic therapies for systemic mastocytosis. 2 medications we use occasionally. So imatinib has been tried and true for many years. A couple really important points about imatinib. So the D816V mutation is resistant to imatinib. So it is critical that you have good documentation on D816V. What that typically means is checking D816V in the bone marrow aspirate. So D816V negative in peripheral blood does not definitively exclude that mutation in any human. Typically, these are at quite low burdens. Mast cells do not really circulate through peripheral blood. They live in the bone marrow. So you really need a bone marrow aspirate to definitively ensure people do not have the KIT D816V mutation. This is really important because probably once or twice a year, I will get referrals for D816V negative patients who are not responding to imatinib. And typically, we've missed a low burden D816V. So the patients will not get better with imatinib if they have D816V. Midostaurin is approved for more advanced systemic mastocytosis, so aggressive SM and the more oncologic indications of SM. It is not currently approved for indolent systemic SM. This medication is a multi-kinase inhibitor, so it has 2 approvals for advanced SM and for FLT3 positive AML. It works quite well in aggressive disease, but has a lot of side effects. For many years, kind of the quest to narrow the targeting of these medications to really improve the side effect profile. All right, moving forward here, I want to touch base a little bit on KIT mutations. So the ongoing thought in systemic mastocytosis is that basically all patients have some activating KIT mutation. We see KIT D816V as by far the most common KIT mutation. Depending on the series of literature, it's in 85 to 95% of humans. There have been many other activating KIT mutations that have been reported, but KIT D816V is by far the most common. So what does the KIT D816V or other activating KIT mutations do? So if you take a look at this figure here, you see KIT. So KIT is an extracellular tyrosine kinase receptor, or RTK, receptor tyrosine kinase. And its ligand here is SCF. Dr. Bitar mentioned it a little bit earlier, stem cell factor. So what happens is stem cell factor will come to the KIT dimerizes and then sends a signal intracellularly. You can see here phosphorylates, ATP, ADP, and this goes on and initiates a stream of events in the mast cell. KIT D816V is right here in the active kinase domain, and it causes it to be constitutively active. So what happens in the presence of D816V is you lose the ligand activation, right? The tyrosine kinase is constitutively active. And so this drives proliferation, it drives survival, and it drives maturation of the mast cells too. We don't have listed here, but it also changes the activation threshold. So these mast cells tend to be a little bit more wobbly and a little bit more likely to activate as opposed to kind of wild type native mast cells. So moving on to kind of the main purpose of this section, targeted therapy in systemic mastocytosis. So a little bit of a busy slide here, but in indolent systemic mastocytosis, I want you to think of the mast cell kind of as a whole unit here. So this is a nicely drawn mast cell, nice circular nuclei, lots of granules in there. Mast cells have really a boatload of ways that it can be activated. We see complement receptors, we can have IgG, we see IgE. Really, regardless of the motivation or the modality of activation, these cells will release a variety of chemicals. So tryptase, we think of histamine, leukotrienes, prostaglandins, and a bunch of cytokines. You can see here, I want to call particular attention to the KIT protein, and specifically KIT D816V. You see avapritinib blocks right here intracellularly in the KIT D816V mutation, and more or less starves the mast cell. It also decreases activation a little bit, but more importantly, it leads to cell death of mast cells. And the purpose here is that all of these symptoms at the bottom can be triggered by mast cell activation, all the symptoms we talked about before. And the central thought with the targeted tyrosine kinase inhibitors is that if you remove the mast cells, you don't need to block the mediators because the cells that are producing the mediators are no longer present. So that's kind of the overarching theory with our targeted tyrosine kinase inhibitors. So moving forward on these medications, I want to talk a little bit about the seminal trial that led to the approval of this medication. So this was termed the PIONEER trial. It was published in New England Journal of Medicine Evidence. Avapritinib versus placebo in indolent systemic mastocytosis. So there were a couple of important things about entry into this trial. So one, patients had to have moderate to severe indolent systemic mastocytosis symptoms. So this was gauged by what we call the TSS, or total symptom score. It was basically a compendium of symptoms across multiple organ systems. So are you itchy? Do you have flushing for skin symptoms? For GI, do you have diarrhea? Do you have bloating? Constitutional symptoms, do you have fatigue? Are you sleeping too much? So we took this combination of symptoms and basically asked patients to rate on a daily basis what their scores were, and we came up with an aggregate score. I think the maximum of this is 44, I want to say, and in order to enter into the trial, you had to have at least greater than 28. Uncontrolled symptoms despite greater than 2 anti-mediator drugs. So typically this would include like an H1 and H2 antagonist. If you were still symptomatic despite these medications, you could enter into the trial. So looking in a little bit more detail, what did avapritinib do? So you can see here a comparison against placebo. Avapritinib is going to be the reddish-orange graph or bar, and then the gray bar is going to be placebo. So how we measure this is more, I would say, like oncology style trial reporting. So we're looking at people who had greater than 50% reduction in all of the following mediators. So you can see here at total symptom score, avapritinib was much more likely, patients were much more likely to have greater than 50% reduction in TSS compared to placebo. And you can see really for all of the questions. So for serum tryptase, for KIT D816V, VAF or variant allele fraction, and for the bone marrow mast cell burden, significant improvement or significantly more patients reached a greater than 50% reduction on avapritinib versus placebo. Focusing a little bit more on the skin here, skin biopsies were required for all patients with skin lesions in the study. So all of them underwent skin biopsy prior to starting medication and 6 months after starting medication. And then we used both the skin lesions and there was also skin photography, which was able to measure the assessment of body surface area involved, the change in pigmentation, and the resolution of cutaneous lesions. So using these two metrics, we can look here at change in skin lesion area at 24 weeks. So that's roughly the 6-month time point that I was talking about. And again, same color scheme here as present. Avapritinib is going to be in the reddish orange and placebo is in the gray. And you can see really across the board, focusing on different areas of the body in all situations, avapritinib has a greater percent change from baseline, a greater reduction in skin lesion areas compared to placebo. So this holds true for the thigh, for the torso, for the front of the thigh, the front of the torso, and then the most affected area. So I would say, mastocytosis is a disease that involves many organ systems, but skin is the most visible organ. And so these skin lesions really bother people and really impair their quality of life. So this represents a significant improvement in quality of life for most of these patients. It's very encouraging findings. Moving forward, many things that we care about in oncology-related diseases are long-term stability and long-term improvement. So it's great that we improve people's quality of life and we reduce their symptom burden, but I think it's equally important to show that that is maintained over a period of time. And so this is what this slide here attempts to address. So we're looking here again at the total symptom score, TSS score, at 96 weeks, so roughly 2 years, and 144 weeks, roughly 3 years of avapritinib exposure. And again, what we're looking for is maintenance of symptom improvement. And in fact, as it turns out, you can see avapritinib at 96 versus 144 weeks. Not only there is maintenance in symptom improvement, there's a deepening of symptom improvement as well. So this holds true up through 3 years of medication. This was actually just published too. I just got an email earlier today that it went live, I think, on PubMed. So if you're more interested in this, go pull up PubMed. There's a bunch of us who are all authors of it here. Moving to the second one, individual symptom domain scores. So if we fragment the total symptom scores into particular domains, so GI, skin, neurocognitive, the same holds true, right? So looking at 3 years, not only do people maintain their symptom improvement, but in fact, it deepens in all 3 domains. And then finally, in the quality of life score, this is spatially separate from the TSS score, but it's another scoring system that we use more generally to measure quality of life. So more along the lines of how often do you avoid doing things that you enjoy doing because of mastocytosis? How often do you have anxiety about going into large rooms or worried about where's the bathroom, et cetera? And again, in this, patients improve over the course of 2 years, and that symptom improvement is sustained and in fact heightened over the course of 3 years. All right, moving forward a little bit, avapritinib's warning precautions and common adverse effects. So the one that patients will always ask about is going to be intracranial hemorrhage. We have seen this. They have been exclusively isolated to patients with advanced variants of the disease at high doses of avapritinib. Really important to note here, I try to, walk people off the edge of the cliff, if you will, in my clinic when they read about this. A couple of points that I would say. So one, we have never seen any bleed worldwide in any human with indolent systemic mastocytosis, full stop. Two, we have never seen a bleed at doses of 100 milligrams or below. Typically what's FDA approved is 25, although many people will use 50. But regardless of those doses, at the ISM dose, it's well below any dose that we've seen a bleed on. I think some of the more effects that are actually more tangible, and we do see cognitive effects. Avapritinib does cross the blood-brain barrier, and from time to time, I will see people who have forgetfulness, memory difficulties, etc. We see a little bit of phototoxicity as well. Maybe most importantly here on the right, embryo-fetal toxicity. Avapritinib, as with all other tyrosine kinase inhibitors, are teratogenic. People cannot get pregnant on these medications. So birth control or two methods of reproductive potential is really important for these medications. So avapritinib is not the only one. It is currently the only FDA-approved targeted tyrosine kinase inhibitor. There are two others that are in clinical trials. So elenestinib in the Harvard trial is currently enrolling patients. We are currently actually on part 2 right now for phase 2/3 trial. So it's a definitive trial, currently placebo-controlled and currently enrolling patients. The Summit trial for bezuclastinib completed enrollment in late 2025. They just released some early publications on it. Looks quite promising. Data is still pending. Full data is still pending on that. That is no longer enrolling patients and not yet, hopefully FDA approved. But looking at the early data that they have, you can see check marks or maybe X's across the line here. Much like avapritinib, they improve symptoms as measured by symptom scores. They reduce tryptase, reduce KIT D816V, reduce mast cell burden, and have a favorable safety profile. So kind of a really exciting time for mastocytosis. We used to have, like antihistamines and finger crossing. We now have an FDA-approved drug, and we have hopefully more coming. So very exciting. Would also mention here at the bottom in the ongoing phase 2 APEX trial, which is an advanced systemic mastocytosis, bezuclastinib also shows very promising data. It's associated with progression-free survival at 82% at 24 months. Again, the advanced variants are very different diseases, so the outcomes are often survival rates, which is very different in indolent systemic mastocytosis. Okay, so a couple of other emerging therapies, masitinib in phase 3 trials. This trial is no longer enrolling. I have not heard much. I do not think this one will pan out. TL895, this is a completely spatially separate medication. It's a BTK inhibitor, similar to remibrutinib, which I'm sure much of the dermatology audience will be familiar with. Rilzabrutinib is another BTK inhibitor approved for ITP. So these medications are currently in clinical trials. There's no early data whatsoever, so exciting to see how this will pan out. Okay, all of that said, let's go back to our post-test question number 2. So Darren has indolent systemic mastocytosis with KIT D816V. I kind of read this, so I'm going to skip over reading it. I will allow people to read again. Again, this is the same question as before. I will be quiet for a minute and let everybody go ahead and answer the question. Okay. Excellent. So avapritinib improved mast cell burden and reduced lesion surface area. So most people got it right. So let's advance the slide here and we can chat a little bit. So yes, D is the correct answer. So results from the Pioneer trial, which we just talked about, show significant improvements in mast cell burden, really across multiple areas. So skin and bone marrow were the two pieces of data that I showed you, and reductions in skin lesion surface area located in all areas assessed across the skin. So yes, D here is the correct answer. With all of that said, I would like to hand it over to, actually, no, wait, hold on, question and answer. And we do have looks like a question here. So what patients would be the best candidates for avapritinib? Yeah, so good question. It depends. So I think in my clinic, it's one of two reasons. So the primary reason is patients who are really quite symptomatic despite control or despite maximal medication or at least a handful of anti-mediator therapies. So there are a lot of people out there who are on cetirizine, who are on famotidine, even those who are on omalizumab, montelukast. And despite all of our best efforts with quite a bit of polypharmacy, often they are still quite symptomatic. In those patients, particularly when their tryptase is elevated, avapritinib often enormously improves the quality of their life. So that's one. I would say two is patients with a little bit more aggressive type disease. So these are patients with very high mast cell burden. So high baseline serum tryptase, significant involvement in bone marrow, high KIT D816V variant allele fractions. So when we see these kind of things, generally we know that there's a little bit of more risk involved in this disease. And I tend to put those patients on avapritinib maybe sooner, even if they're only moderately symptomatic. And I got one more question here. I think I have 1 minute. So how long can you use AYVAKIT in kids and adults safely? This is a good question. So I think, one of the main downsides of avapritinib, we don't really have an off-ramp at this time. I kind of think of this disease as a much earlier version of something like CML. So in CML, the oncologists will treat with tyrosine kinase inhibitors for typically 5 years, sometimes more or less, depending on the specific context. And then they pause therapy and they can often observe. We do not have sensitive enough tools yet. Mast cells don't live in peripheral blood, so we're quite a bit behind them. But in general, the conversation that I have with my patients right now is that once you initiate avapritinib, you will be on this over the long term. I do think this is changing as we have more potent, more targeted tyrosine kinase inhibitors that appear to lead to deeper recession. But for now, it's an open-ended question, and I would say long term. With that, I'll be quiet here and hand it over to Dr. Ungar.
All right, thank you very much. Good evening, everyone. I'm going to discuss the section of centering patients in long-term systemic mastocytosis care. And as before, we're going to start with a case. So Margot has a 3-year history of indolent systemic mastocytosis. She presents to derm for a checkup. Her cutaneous disease is stable. She is experiencing some flushing and increased itching. Margot reports challenges with managing her lifestyle triggers and is concerned about how systemic mastocytosis affects her daily life. She has a history of anaphylaxis caused by a bee sting 2 years prior, osteopenia, hypertension, and hyperlipidemia. So we'll start off with a question and then jump into the meat of this. So which of the following strategies would you recommend for Margot to prevent any life-threatening reactions caused by her indolent systemic mastocytosis? Limit physical exertion to prevent future attacks, prescribe an antihistamine to use on demand in case of an allergic reaction, carry an epinephrine autoinjector in case of future anaphylactic events, trial an elimination diet to reduce dietary triggers. So we'll give everyone a moment to answer that. All right, so the majority of people picked C, carry an epinephrine autoinjector in case of future anaphylactic events. All right, so there are a couple of trends that I'm going to be discussing. You're going to hear me repeat over and over again, and 2 in particular that I think are important. The first is that this is a multi-organ, multi-system disease, and therefore requires multi-system, combined and coordinated care. And the second part is helping patients to be empowered and participate in their care and understanding what this disease means for them and how to navigate it. And those are the 2 overarching trends because this is a complicated condition. Symptoms are often not so specific. It's very possible that patients have not been able to identify always what's going on with themselves. Maybe they've seen providers who have been dismissive, as can be the case with conditions that have very vague multi-system kind of symptoms. And so, I'm a dermatologist. Dermatologists are not necessarily always going to be the primary focus or the point person for treating this, but we can play an important role in making sure that we really establish that dialogue with patients and ensure that they're seeing the specialist that they need to. So with mast cell diseases, one of the roles that we can play is educating patients on certainly what's going on from a pathophysiologic perspective, high level, but also what that means on a daily basis. So knowing their triggers, it may very well be that they've identified some themselves, but nevertheless, avoiding allergens, stress, kind of easier said than done often to manage stress, but that can certainly play a role. Be aware of triggers like temperature changes and carry epinephrine at all times, which we'll return to as well. So common triggers in systemic mastocytosis. Again, patients will often identify some of these, but nevertheless helps to kind of make it a little more clear cut. So temperature changes or extremes, stress, fatigue, certain foods and beverages, medications, infection, Hymenoptera venom. So that's bees, wasps, stinging insects, surgeries and procedures. And again, much of the role that we can play is empowering and educating patients so that they know in advance how to handle things as they come up. So whenever possible, referral to a specialized center for systemic mastocytosis management is recommended because this is complicated. And, in an ideal world, people who really focus on this are going to take the lead. Now, that's not always possible. And so it is also important to understand some of the immediate steps and to know who to connect patients with, even if it's not at a specialized center. So baseline DEXA scan is recommended. If you feel comfortable doing that, great. If not, ensure that they're connected with someone who can order and interpret the results. Patients with systemic mastocytosis are at high risk for osteoporosis, bone fractures, in particular vertebral fractures. And so getting that baseline is important to diagnose them and also track over time. We talked about counseling, advising patients to avoid known triggers. In particular, as we'll see, the venom, the Hymenoptera spider and all that, that's a very high risk factor for anaphylaxis. Certainly, it's important that we make sure that they have auto-injectors of epinephrine because they are at very high risk for anaphylaxis, and having that plan in place before they experience anaphylaxis certainly is key. And ultimately, navigate and kind of assess over time what their symptom burden is, what the quality of life impact is, because so many of the symptoms are nebulous and kind of diffuse or intermittent, and kind of all of these really not sometimes what feels non-concrete. Putting that all together in terms of their quality of life can be helpful. So we've already kind of touched on anaphylaxis a couple of times, but it really bears repeating. This is essentially the primary life-threatening consequence of certainly immediately life-threatening consequence of mastocytosis. The prevalence is up to 50%. This was one study that showed, almost a third of people are going to the emergency room for anaphylaxis. A very non-trivial proportion have used epinephrine more than once. So when someone comes in, perhaps as a dermatologist, we're the ones diagnosing them initially. And then in addition to connecting and all that, making sure that the patient understands what anaphylaxis looks like. People may be familiar with the term at a high level, but not the specific signs and symptoms, access to and training on epinephrine injection, and a treatment plan. And part of this is because anaphylaxis is a very stressful, kind of panic-inducing outcome. Things can progress rapidly. And if patients don't know in advance, have a plan, don't know what to do, that's really not the time to figure it out. And so having this action plan in place, having the epinephrine training is crucial. And then the symptoms as well. And it's worth noting that systemic mastocytosis patients are perhaps more typically that other experience kind of hypotensive syncope as part of their anaphylaxis. So again, having them be aware that lightheadedness may be a precursor to more significant reaction. Hammering home the idea of multidisciplinary care. So this was one study looking at what the diagnosis and management breakdown is of systemic mastocytosis across different specialties. Perhaps not surprisingly, hem-onc and allergy immunology in many respects taking the lead, certainly on management. I think not surprisingly, derms have the most disparate diagnosis to management because it may be that there are these nonspecific symptoms, but they come in for the skin findings. It's relatively straightforward to biopsy, identify the mast cell infiltrates, and then ultimately get the process started on a concrete diagnosis. But that's one piece of the picture. I don't think most derms are going to be treating GI symptoms, allergy symptoms, and so on. And so connecting with an allergist, endocrinologist for osteoporosis. Again, I don't think most derms want to treat or feel equipped to treat osteoporosis, but we can play a role in ensuring that they're connected with someone who will. So endocrinology, psychiatry, depression, other psychiatric symptoms play a role in this very frequently, and having that connection and so on. So, in many respects, we can get the ball rolling on having patients see the correct specialties to ensure this multidisciplinary care. The therapies are numerous because there are so many aspects, different kinds of symptoms, different organ systems involved. Some of them we heard earlier can be helpful in multiple respects, antihistamines and so on, but the consequences also need to be treated. So osteoporosis may require bisphosphonates. Certainly we talked about epinephrine, the various treatments that Dr. Giannetti spent a lot of time on. It's important that these are kind of getting put into action. But it also makes it difficult for patients because with a lot of treatments, there's polypharmacy, there may be different dosing schedules, regimens, different times. And so this kind of segues a little bit into part of the other aspect that I brought up earlier, which is the shared decision-making. So especially, the idea of shared decision-making, which is including patients in the process of identifying goals, treatment strategies, and so on, really transcends systemic mastocytosis. This is really a kind of approach that should be incorporated to all patient care. But there are some conditions where I think it plays a particularly important role. And something like this, where there is such a symptom burden, where there's a lot of treatment burden, it's important to elicit from patients what parts of their disease really impact them the most, that they want to focus on. Maybe they don't have time to go to 7 different doctor's visits in a week. Which are the ones that they should be prioritizing, and then which ones can wait a little longer, and so on. And it's going to be different from person to person. And so that's really the idea here, is seeking the patient's participation, helping empower them, educating them about their disease, and giving them some ability to buy into the treatment plan. When in an ideal world that wouldn't be necessary, we'd wave our wand and all aspects would be treated, but that's not the reality. And so helping them to play a role in that really is crucial. And part of the consequence of that is that patient buy-in is going to lead to better adherence and ultimately better outcomes, because they feel like they're playing a role in their treatment. So here are some patient support resources. Very frequently, I'm talking about educating patients, counseling them, connecting them. The reality is often clinics are very busy, and there may not even be enough time in one visit, one conversation to get all of that done. But, providing patients with some resources to read at home, to look into things, can be helpful. And then, maybe they follow up and there's the potential for productive conversation that is not starting from scratch, but based on a lot of this background information that's put in terms that's accessible to the patients. Okay, so we're going to return to the question from before. Margot has systemic mastocytosis, having some symptoms. Which of the following strategies would you recommend for Margot to prevent any life-threatening reactions caused by her indolent systemic mastocytosis? Limit physical exertion to prevent future attacks, prescribe an antihistamine to use on demand in case of an allergic reaction, carry an epinephrine autoinjector in case of future anaphylactic events, or trial an elimination diet to reduce dietary triggers. So we'll give everyone a few moments to answer. All right, the vast majority of people identified epinephrine. And again, epinephrine is not the only treatment that's going to play a role here by any means. Things like antihistamines, dietary triggers, and so on are important. But in terms of preventing a life-threatening reaction, that's really focusing on the anaphylaxis risk, and epinephrine autoinjector is key for that. All right. So some key takeaways, and then I think we have a few minutes for some questions as well. So please submit in the Q&A if you do have questions. So some key takeaways: refer patients for further assessment if systemic mastocytosis is suspected, ideally to a center that specializes in management of this condition. If not, nevertheless, further assessment is needed. Treatment options for systemic mastocytosis include anti-mediator therapies and cytoreductive therapies. And we heard of different kind of aspects about those. Selective KIT inhibitors are important emerged treatment options because KIT mutations, particularly KIT D816V, are drivers of the pathophysiology. That targeted approach really is the way to address that. And people with systemic mastocytosis commonly receive many treatments and need adjustments. Communication with patients and HCPs is critical for optimal care, again, in that multidisciplinary setting. All right, so we have a few moments for Q&A. So I do see one here that I'll get started with. So how early should patients with systemic mastocytosis be referred to assess bone health? So, I think the short answer is immediately, or within reason immediately. Patients are at high risk for bone disease, osteopenia, osteoporosis, fractures, and there's really no benefit to pushing that off. Either they're going to have more normal bone density and so on, and can be connected with an endocrinologist, let's say, for more preventative approaches, or they need to be treated as soon as possible. So the short answer is essentially right away. Right. Give a moment or two for additional questions. All right, we do have another question. Maybe Dr. Bitar, I'll direct this to you. So what can you do if a patient's GI symptoms improve, but their skin lesions remain burdensome?
Yeah, and I think this is what I was talking about, and we see that in autoimmune disease as well. Like sometimes patients do get better in the other symptoms and the skin will lag behind. So as Dr. Giannetti mentioned, like there are skin targeted therapies. So you can start with your antihistamine, and then like I do use a lot of Xolair as well, as Dr. Giannetti mentioned, which is the omalizumab for like skin. We sometimes, so there are some talks about like dupilumab, which is an interleukin 4 and 13 that also can control some of those pruritus, itching in patients. And then if you do want to have a like a kinase targeted therapy, then like I think they'll be like in the more advanced stage, as Dr. Giannetti mentioned. But for the skin in particular, like definitely all of them will be on antihistamine first and second generations, and in addition to omalizumab, and sometimes considering as well like an interleukin 4 and 13 inhibitor, and then like definitely now with the new BTK inhibitor for CSU, so that's like another consideration as well.
All right, thank you. And then Dr. Giannetti, I'll pass the next one to you. So how does avapritinib decrease the mutation?
Yeah, I assume this is asking about KIT D816V. So avapritinib has quite a bit of selectivity over wild-type KIT. So as it turns out, the KIT D816V, it's a single point mutation that changes, I'm using my hands here, changes what the kinase pocket looks like. And so avapritinib and the other tyrosine kinase inhibitors are designed to target that pocket. So it specifically targets that pocket much more than wild-type KIT. And it, for lack of a better word, turns off the KIT signaling. And so stars cells is how I describe it to my patients. So you are selectively eliminating KIT D816V bearing cells as opposed to wild type KIT cells. So when you measure the variant allele fraction, it's a simple measurement of KIT D816V reads over total reads. And if your KIT D816V reads go down and your total reads stay the same, you have therefore decreased the mutational burden, mostly by the effect of killing off or eliminating the KIT D816V mutational bearing mast cells.
All right, thank you. And then I think we have time for one more question, and we have one more at the top of the list waiting. So actually, Dr. Giannetti, I'll go back to you. Patient anticipates hepatic transplant. Can avapritinib be used at the same time?
No, I would say. So there is a risk of bleeding with these medications, some intracranial bleeding, but bleeding more generally. I would, it depends on what they're anticipating hepatic transplant for. I need a little bit more context here, but no, I hold avapritinib prior to surgery for about 3 to 5 days prior to surgery. I would say one possible exception in aggressive mastocytosis, people often have hypersplenism, portal hypertension, and in that case, which you have liver failure as a result of aggressive mastocytosis, the right answer may be to use avapritinib to cytoreduce, but that's a very specific case in which the primary cause of liver failure is systemic mastocytosis. In all other situations, the answer would be no.
You have been listening to CME on ReachMD. This activity is provided by Clinical Care Options LLC, doing business as DeSera Clinical Education. To receive your free CME credit or to download this activity, go to reachmd.com/CME. Thank you for listening.